Welcome to our third module. This is a topic I'm actually super passionate about, but I think is not as exciting or maybe fun to talk about as the other common topics like ADHD and autism. So I'm really pleased to share this with you because I actually have a lot of experience working with kids with sometimes pretty severe behavioral problems. And just statistically speaking, a lot of kids out there have behavior problems. And I think it's really important as integrative providers and naturopathic doctors to address really the root cause of what's going on for these kids. So I was surprised actually to learn, I knew that ODD was pretty common, but I did not realize it is actually the #1 cause for referrals for youth mental health services. So 2 to 16% of children have a diagnosis of ODD at some point in time. And then of those kids, about 92% meet criteria for at least one other lifetime DSM disorder. Mood disorders occur in 45% of those patients, anxiety in 62% of those patients, impulse control issues in 68%, and substance abuse in 47%. And it should be noted, this is based on stats from this country, but the worldwide prevalence is around 3%. So lots and lots and lots of kids. So what classifies oppositional defiant disorder? Well, it's of course like defiant behaviors, which I think we should probably all figure out, but essentially kids are argumentative, angry, or throwing tantrums, refusing tasks, blaming others for mistakes, not following the rules set up by authority figures. And then there are some gender differences. And then obviously this is a generalization, but this is actually listed in research that girls tend to be manipulative and boys tend to be aggressive. And of course, those features change depending on the personality of the kiddo, but that actually has been documented in literature as well. These are really good screening questions for ODD that you can use in clinical practice. You can ask things like, has your child been spiteful or vindictive? Are they touchy? Are they easily annoyed? Do they lose their temper? Are they deliberately annoying to others? Which if a kiddo has a sibling, the answer is going to be yes for all those. But essentially, is it beyond what we would be expected? And then in my opinion, as a naturopathic doctor, though these questions may lead to a diagnosis of ODD, they do not rule out other conditions. And that's really what I want to go through today. So this is the diagnostic criteria of oppositional defiant disorder. At least 4 of these symptoms need to be present for more than 6 months on most days of the week. So it's not like kids have this intermittently, because every child, if they're a normal growing up kiddo, is going to have some of these symptoms at some point because they're growing and they're human and we're all human. But if they're having them for 6 months on most days, that's the criteria there. The behaviors have to interfere with life in some way. In other words, there needs to be an impact on family dynamics, education, work, and that patient should not have behaviors that are solely from another psychiatric, behavioral, or mental health disorder. By the way, DMDD is disruptive mood dysregulation disorder, and these kids have temper tantrums at least 3 times a week. They're chronically irritable, angry most days, and the symptoms must happen regularly for at least 12 months. Some kids may meet the criteria for DMDD and ODD simultaneously, but then DMDD is considered like that supersedes the ODD. DMDD affects 2 to 5% of kids in the US, and the symptoms usually begin before the age of 10. And then compare this to conduct disorder. So this is ODD versus conduct disorder. I really wanted to go through more conduct disorder in this course as well. Originally, I named this ODD and conduct disorder, and then quickly realized it's just way too much content. But let's go through the criteria, because there is a risk factor for ODD leading to conduct disorder. So conduct disorder is actually quite severe. It's more of a pattern of severe antisocial behavior, and that sometimes leads to criminal behavior. I will have information in the NatPeds Pro document, so that's summary underneath the video, that has the diagnostic criteria of conduct disorder. But basically the signs are, severe violation of rights. So early signs could be hitting, pushing, or biting others, which is entirely normal in the toddler period, but should have resolved in early childhood. And then later signs and symptoms could be more serious offenses like fighting, stealing, vandalizing, abusing drugs, alcohol, skipping school, arson, violence, etc. And it's really important to treat and diagnose ODD because untreated ODD can end up with a diagnosis of conduct disorder. And then a lot of those kids are going to end up being in the criminal justice system. So having lack of treatment is a poor prognosis for ODD, but on the other hand, good treatment, good co-treatment with the other coexisting conditions and positive parenting are associated with good prognosis for kids with ODD, oppositional defiant disorder. So I hope that's clear. So what's the etiology of oppositional defiant disorder? I mean, a lot of people think it's just kids being kids, but there are actually some really clear risk factors. I thought this part was really interesting. So the etiology is pretty complex. There's multiple factors, biological, psychosocial, and social factors. Theories suggest that kids with ODD might have deficits in specific cognitive and emotional skills that might contribute to their oppositional behaviors. So that might include things like problems with executive function, problems with working memory, difficulties in emotional regulation, affect modulation. That makes it challenging for kids to actually comply with the requests that adults are giving to them. I really liked this study, was super interesting. So this study suggests that children with ODD have lower gray volume matter in the cerebellum, and especially in areas of the brain involved in executive function, which, by the way, I didn't quite realize that the cerebellum, that connection is involved in that executive function. So that was a really interesting study. And then there's genetic factors involved as well. And this is the part I'm pretty excited about. I've been talking about these single nucleotide polymorphisms for years, and I want to go through them pretty clearly in this course. But the two SNPs that are associated with ODD is the MAOA gene and this 5-HTT-LPR gene, and we'll go over that in just a little bit. So parenting is predictive for ODD, unpredictable, inconsistent, harsh, abusive, heavily punishment-based parenting styles or escalating parenting tactics are associated with oppositional defiant disorder. And just a reminder here that the parent-caregiver connection is absolutely critical to brain growth in children. That good attachment to the primary caregiver is really the foundation for all future relationships. It helps the child feel secure, and it's just super important for growth and development. Just kind of a plug, if you haven't already done there's a training called Promoting First Relationships, PFR. And the whole idea of the training is for us as providers to establish and nurture the connection between that primary caregiver and the child. It's really critical, and doing that training really changed the way that I use language around parents. So basically, not telling parents what they're doing wrong, which I feel like, unfortunately, was a skill that I learned in naturopathic school. It was like a lot of judgment-based, all sorts of things. And how I've reframed it is starting to notice the connection between the parent and the child and point it out to them, basically point out what they're doing well. And then when they're mentioning parenting tactics that you don't think are that great, we usually start with noticing what they're doing well or saying, I hear you care. And then moving on to, hey, we know that this kind of parenting strategy works better for this child. So in other words, we're not criticizing or cutting down parents. That really starts to sever that relationship. Parents start feeling a lack of confidence in their parenting ability, and it's really important that they continue to feel confidence. So it might sound like not a big deal, and it is a very big deal. And in the well child checks in my office, it is the number one thing that I'm doing is assessing the bond between the caregiver and the child. Other risk factors for ODD, mental health problems, paternal mental health problems, substance abuse in pregnancy, issues with temperament with the child. Of course, we know some kiddos are more challenging than others. Of course, the harsh or inconsistent child rearing factors, practices. And then there are some genetic markers too, the lower heart rate and reduced basal cortisol reactivity. There's changes in the prefrontal cortex and the amygdala. And we haven't always separated those from kids with ODD from those with conduct disorder. So we don't really know if they're specific to ODD or not. And then why is there a higher rate in boys? There is about a 1% difference, 1% higher rate of ODD in boys. We know that testosterone, which of course is the primary male sex hormone, is linked to aggressive behavior. Higher levels of testosterone in boys can contribute to increased aggression. I feel like everybody probably knows that. And then we know that studies that have shown that the brain area that's related to aggression and social dominance is affected directly by testosterone, so upregulated. And then we also know that testosterone impacts social bonding and empathy. So basically, boys with higher levels of testosterone have reduced sensitivity to social cues and to social behaviors. So it's harder for them to form bonds. And then there's also this really interesting interplay with testosterone, vasopressin, and oxytocin. So I don't know how much you guys know about this. Wasn't something I learned about in school, but there's a lot more information now about oxytocin and vasopressin, particularly in autism. And I found a really great study I'll show with you at the end. But vasopressin is a hormone that's involved in water retention in the kidneys, but it also plays this really interesting role in social behaviors, especially in males. It promotes protective and territorial behaviors. And then it helps in that formation of social bonding, but really it is involved in like mate guarding. So there's this protection kind of aspect of it. And then the flip side to that is oxytocin, which is often called the love hormone, which of course is involved in more maternal behaviors, social bonding, and that's forms like the connection and trust. And that's heavily involved in social connections. So it's really interesting. There's this really interesting interplay between the three, and basically high testosterone levels are dampening the effect of oxytocin, and then they enhance the aggressive and protective effects of vasopressin. So this is probably why boys have that sometimes less of a social connection than girls. And then of course we know like boys with a double Y chromosome make more testosterone and tend to have even worse outcomes. Great study. Okay, and then there's other reasons, of course, too. So I'll go over these quickly, but basically the studies have shown that boys often externalize their stress and girls internalize. I know this is a gross generalization. This is not true of all, but this is well studied in literature. And then boys might seem to be more sensitive to environmental triggers as well. So let's talk about really quickly some tools for diagnosing ODD. Really, the first step is just to conduct an interview with the child and the parent. We do have some questions, sample questions in our charting templates. I really strongly prefer using that Vanderbilt ADHD assessment. Most of the time in like neuropsych or a psychologist, they're going to use a Conners or the CBCL or the BASC. I looked to see if we could get a copy of that, and I could be incorrect. So if someone has a better answer for this than me, let me know. But it was expensive. I think it was somewhere between $90 and $400 to purchase a Conners, and it doesn't really seem, it doesn't seem necessary to me. I really like the Vanderbilt. There is a very small section in the Vanderbilt about oppositional defiant disorder. And one study actually showed that answering a yes, or essentially the answers are often or very often to two of the questions on the Vanderbilt, and I'll list those in just a sec, has very good sensitivity and specificity for diagnosing ODD. And those questions are actively disobeys or refuses to follow adults' requests or rules, or the question is angry or bitter. So answering often or very often to those two has a very high likelihood of ODD. And of course, I would definitely consider referring to neuropsych or a psychiatrist. I gave the reasons why, but I feel like in most cases of ODD, they have overlapping mental health issues, and it can be really helpful to determine those. This, I think, is the most important part of the webinar, and that's because ODD has so many conditions that it looks similar to. So I kind of wanted this lecture to be called Why I Think ODD is a BS Diagnosis, but really say it out. But I don't know, I'm not up to swearing, I guess, yet on a webinar. Maybe I'll grow into it like Dr. Anderson, we'll see. Essentially, ODD really only describes the behavior of the child. It doesn't talk about why, and what I'm interested in as a naturopathic doctor is the why. So let's go through these. ADHD. It's super important to understand that 40% of kids with ADHD also have ODD. And again, that's why I like the Vanderbilt for assessment. Of course, ADD is usually like inattention hyperactivity, but the impulsivity is there. And sometimes the impulsivity means they can't stay on track, or the inattention means they're not following the caregiver's instructions because they are forgetting. So that's really important. And then ODD versus depression. I mentioned this several times in my social media posts in the last month. It is really hard for me to see a kid in my practice who's been diagnosed with ODD, because really when kids are diagnosed with ODD, they're kind of labeled like bad kids, but they're really depressed. And most of the time in my practice, when kids are depressed, they have something medically wrong with them. So kids with depression, remember, do not look like adults with depression. We don't see the same, like sadness or anhedonia. Usually kids with depression are grumpy or irritable first, maybe moody, withdrawn, and then they start to refuse things. So they start to refuse to clean their room, they refuse to do their schoolwork, they refuse all sorts of stuff. And that's not coming from a place of defiance, but out of depression. So it's really important to really weed that one out. Again, that overlap of other mental health disorders with ODD, in my experience, is, I mean, I honestly cannot remember an ODD child that I've seen that does not have another severe mental health coexisting condition. So we can use PHQ-9, and there is an adolescent version of that. It's a special adolescent PHQ-9. It doesn't really translate well for younger kids as a screening tool. There is the Bright Futures CESDC, which is the Center for Epidemiological Studies Depression Scale for Children. I said that one fast. And I think I have a link in that NatPeds Pro document, but you can also just Google it too. And I did speak about this a lot last month, but it's so important to check for other causes of depression. I think most kids have something else going on. Iron deficiency anemia is number one. I've also seen low vitamin D. Even just fixing low vitamin D levels improve kids' mood, hypothyroidism, constipation, headaches, chronic infections, and on and on and on. We have to make sure that kids don't have an intellectual disability. If they do, they're only diagnosed with ODD if that behavior is significantly greater than what we would expect for that intellectual disability anyways. And then make sure that they can hear before they're diagnosed with defiant behaviors, because if they can't hear, then of course they can't comply. So check the ears. This is really important to me. A really commonly missed diagnosis is autism spectrum disorder level 1, which is previously called Asperger's syndrome. And I see this a lot. So autism meltdowns can absolutely look like defiant behaviors. Remember that level 1 autism is characterized by missed social and communication cues, but some of these kids you may not notice. Some of these kids are great at masking. They've learned masking behaviors. And so you might notice the defiant behaviors first. Remember, these are kids that usually never scored positive on the autism screening questionnaires in toddlerhood, because they just, they're verbal, they're speaking intellectually, they're there, but they might have some of these other characteristics. So the other characteristics would be lack of emotional reciprocity. They're not forming those social emotional relationships. They're missing social cues, lack of eye contact, difficulty making friends, things like this. And then the other part that I feel like is sometimes noticed more is like special interests. Most level 1 autists have one special interest at a time, and they'll talk about nothing else. Some of these kids absolutely insist upon sameness. They might have a really inflexible adherence to routines or like rituals. They have to have everything the same way every single day. They want the same food at the same time, or they have like a ritual before going to bed or when they're getting picked up. And if these kids have a break in routine, or like aren't allowed to line up their toys or have something out of order, they might have meltdowns or defiant behavior because of this internal distress, the dysregulation or the overwhelm. So it's pretty sad, again, to see these kids diagnosed with ODD when it's an autism meltdown. A lot of these kids, of course, have sensory issues. They could be sensory seeking or sensory avoiding, or even at the same time. So we could have a kid that is a really super picky eater, avoids scratchy clothes, avoids loud noises, but then they love to swing or spin. So remember, we've got our five senses, but then we also have the vestibular system, which is the inner ear. So it'd be swinging, spinning, bouncing. And then we have the deep tendon organs as well. So there would be kids that respond to like deep pressure or touch. Or like you could have the reverse, a kid who avoids swinging or bouncing. That's also really common, but maybe they're obsessed with music or noises or something else. So be mindful of this. It is very easy to miss, especially in girls. A lot of the girls are hypersocial, so you might miss a level 1 autism diagnosis. And again, that's like kind of a gross generalization, but it's easy to miss this in kids that are very verbal and often highly intelligent. So they're great at talking to adults, but they're missing social cues among their peers. So we might miss it as a caregiver or as a provider, or the caregiver might miss it if the kiddo is really verbal with them, but they're not making those connections with other friends. And then please remember this slide. I'm really passionate about this topic. I will go through a whole section on parenting strategies for kids with PDA. So this is pathological demand avoidance. It's a proposed subtype of autism, and it's characterized by an extreme avoidance of everyday demands and an anxiety-driven need to control situations. It's not officially recognized in all diagnostic manuals. And in fact, even the neuropsychologist that I refer to, who I really respect, has told me to stop putting it in my list of potential problems for kids. But my other neuropsychologist friend has diagnosed dozens and dozens and dozens and dozens of patients with pathological demand avoidance. And in fact, she wrote an article on naturopathicpediatrics.com on PDA. So you can pull that up after this. It's a great article. So she's the one that helped me recognize this in kids. It's well recognized in the UK. There's not a lot of recognition here in this country, but it's just starting to be. So let's go through a little bit. I think I've got another slide on. Yeah, okay. So it's characterized by this just extreme anxiety. These kids are having essentially panic attacks or near threshold panic attacks all the time. And they're avoiding even basic demands because their need to control situations is just overwhelming. So that's the key to diagnosis here. It's an overwhelming desire to be in control and avoid being controlled by others. They should show some other signs of ASD as well, like missed social cues, but some they again sort of like appear socially, like they appear social, but they're like maybe socially inappropriate or manipulative, or they're just like something's off essentially. So, and I think that's what Dr. Neff put in that article about PDA on naturopathicpediatrics.com. Like, have you ever seen a child where something's just off? That's how this presents typically. Other characteristics, they might have mood swings, they might be impulsive. Many are engaged in major fantasy play or role play. They can be like totally immersed in that world. They can have a lot of other symptoms of level 1 autism, especially like the rigid behaviors or rituals. And again, they often have like the one special interest at a time and just talk about it all the time. And I mentioned this, well, one, again, if you start talking about pathological demand avoidance all the time and you put it in your chart note, you run the risk of all sorts of people calling you all sorts of names, which is my experience. But I've found no other helpful strategy for parents, even when kids don't meet the criteria for ASD. So we talk about this a lot, this like overfilling cup. Most of the kids with defiant behaviors have anxiety. Again, 62% are diagnosed with anxiety, but I feel like the majority have some form of anxiety. And so essentially what you're doing is you're asking a kid who's drowning to then get their shoes on. And they're refusing to do it because they feel like they can't handle what they already have going on, and you're just adding something else to them. So using this strategy of talking about PDA, even if they don't really meet criteria, has been very effective in my practice. Other conditions too that might also look like oppositional defiant disorder, substance abuse, of course, sleep apnea, you better bet. How do kids or adults act when they're sleep deprived? They're irritable and they have mood swings. And then constipation, I mean, I definitely see that too. The kids that get really grumpy and irritable before they have a PM. So key is if they have a poop and their behavior resolves, then they're probably constipated. And again, go back to my constipation webinar, but some kids can be having daily bowel movements and still be constipated. And then of course we don't know cause and effect on that one. So reactive hypoglycemia, you better bet. Yes, irritability, mood swings. And then the key to that is usually behavior problems that are an hour and a half, is usually right around 90 minutes after a high sugar meal, that insulin comes up, drops, blood sugar comes up, drops. That is pretty key, or kids whose behavior problems resolve after eating. So let's go over the SNPs, the single nucleotide polymorphisms. I'm so excited to share this because this has been my, I don't know, is it my special interest? It's my thing that I really like to talk about for a long time. And again, my colleague, Melissa Neff, and I were years ago talking about writing a book on this one because we have a lot of shared patients with the MAOA gene. So MAOA, and this is a specific MAOA polymorphism, the UVNTR. This has the most research for being associated with ODD. So if you don't already know, monoamine oxidase A gene codes for the MAOA enzyme, and that's responsible for breaking down the neurotransmitters serotonin, norepinephrine, and dopamine. When I talk about this with families in my office, I'm often going through like a methyl cycle. A lot of people have heard of MTHFR by now. So we'll like go through the methyl cycle, and essentially the end product of methylation is turning on happy brain chemicals, is how I call it in my office. MAOA is essentially turning off happy brain chemicals. So it's really the opposite of MTHFR, which is why it bothers me when people kind of treat MTHFR alone without looking at MAOA, because if you give an MAOA patient methyl B vitamins, they're going to flip their crap on you. So this is specifically talking about MAOA low, a low variant, low activity variant, MAOA L. And the specific studied variant is the UVNTR, which, by the way, is not found in a lot of the reports that we can pull. So if any of you do the like ancestry.com and then you pull the raw data file out and you go to the special website and all that kind of stuff to look at SNP reports, which is what I do, it will show MAOA genes, but it won't show the UVNTR, and that's because it's in the promoter region of the gene, and it corresponds with really low enzymatic function. So the result is excessively high levels of serotonin, norepinephrine, and dopamine. And this study shows that carriers of the low MAOA activity alleles have reduced limbic volume, they have amygdala hyperresponsivity, they've reduced prefrontal cortex activity. So remember, that's a lot of executive function too. And then those, like essentially those markers have been like assumed, or they're like, that's what they think is the relationship between those specific markers and the antisocial behaviors. So they already know that amygdala problems, small prefrontal cortex is linked to antisocial behaviors. And so they're thinking that the MAOA is contributing to that. I hope that makes sense. So the clinical symptoms here, these kids below their tops, they have super high levels of serotonin, norepinephrine, and dopamine, and it lasts a super long time. They're borderline panic attack threshold all the time. So we were talking about filling the cup. They're already overflowing the cup. When these kids are exposed to any sort of stress, their adrenaline spike is high and doesn't come down for a long time. When I'm describing this to families, what I say is, for a normal person, their level of adrenaline is here. Their experience of stress, they come up and then it comes down. For these kids, one, their threshold, they're already here. They're starting way higher because they can't break this down anyways. They get a stressor, they come up, and then they stay there for a super long time. So it could be, it could be maybe hours before they come back down again. So a lot of these kids will have other symptoms similar to like adrenaline spikes. So they'll have insomnia, anxiety, stomach aches, mood swings, impulsivity, and violence. Most of these kids will explode. And then oftentimes they feel really remorseful afterwards. So that's kind of the sad part. They explode and then they're actually sort of like burning off all the adrenaline. And then they feel better in their body and then they regret what they just did. So that's often what's happening. And a lot of parents are describing it like they kick the wall, they punch, and then they're crying and then they're sad and then they wish they hadn't done it. So for a lot of these kids, they just don't know what to do with all of this extra internal stress. So the clinical effects, combining a low activity MAOA gene and then adding in an adverse child event is very likely to result in a major behavioral issue. These kids are way more sensitive and vulnerable to environmental stressors. Also worse than boys, MAOA is X-linked. Males only get one copy of the gene anyway. So if they get one copy, then they have MAOAL. Testosterone actually affects the gene expression, so it can make it worse. And then females, on the other hand, actually benefit from the protective effects of estrogen and progesterone. So progesterone can provide some neurostabilizing effects. It gets converted to allopregnenolone, which acts on the GABA receptors, and that calms the brain. It's like natural Xanax. And then estrogen can actually upregulate the MAOA enzyme itself, so for expression. A low MAOA is associated with increased rates of violent crime and incarceration, and unfortunately, this is worse in African-American boys. And this is showing a, quote, robust association between low activity MAOA alleles and violent crime. They've studied this in prison populations. So in other words, MAOA kids must be well supported. And then for a separate gene, this one was a little bit more new to me. We have the 5-HTT-LPR, which is a genetic variant of a serotonin transporter gene. So this affects how serotonin is transported into the brain. It has been linked to ODD, but specifically it's associated with less resilience to environmental stressors. So it's not a direct one-to-one. It is basically a 1 + 1 = ODD. So the research shows, of course, that serotonin function can lead to just various issues. And here I'll show you this next study. So it's basically showing that this gene plus life stressors predicts all sorts of negative mental health outcomes. Depression's a major risk. It also increases risk of suicidality and major depressive events following life stressors. So kids don't have the emotional resilience when they have this gene. And then here's the real, like, I think fascinating part, but this is like kind of the summary slide here. You combine the two genes and a stressful life event, and that is the highest rates of the worst behavioral outcomes. So adding the two genes together plus either a family conflict or a sexual abuse has the highest rates of teenage delinquency, mental health issues, behavior problems, ODD, and conduct disorder. But interestingly, the same kids with positive family homes actually have the best outcomes. So environment matters for these kids. All right, so let's look at laboratory testing really quickly. And there isn't like a lab test that diagnoses ODD. It just helps us figure out if there's a cause that might be affecting mental health. So same thing, my standard pediatric labs that I talked about a lot last month, CBC, CMP, TSH, all those kind of things. I do really recommend, if they can afford it, adding in some of those nutritional tests. So sometimes you can code for nutritional deficiency, I think unspecified, and insurance will cover this. So B12 folate, RBC zinc, RBC mag, serum copper, and then I would consider celiac disease testing just as a screen. If there's maybe any concerns about abdominal pain, I think all kids should be screened for celiac at least once. This study shows that low plasma vitamin B12 levels was associated with higher externalizing behaviors. Basically, externalizing behaviors is defined as aggression, delinquency, and hyperactivity. This is a tricky part with a lot of these studies. The externalizing behaviors is oppositional defiant behaviors, but they don't say B12 is associated with ODD. They link the behaviors to the deficiency, not necessarily the diagnosis. So I just want you guys to be clear with that. So B12 deficiency, definitely associated. This one is really interesting. It measured vitamin D levels in elementary aged kids, so children age 5 to 12. And then it assessed behavior problems 6 years later using the child behavior checklist, which is one of the diagnostic tools that we use for ODD. And kids who had vitamin D deficiencies in childhood had significantly worse behavior problems 6 years later. So this is really interesting and I think critical for prevention here too. This study shows that whole blood magnesium and zinc levels are inversely related with behavior problems. So in other words, the lower the magnesium and zinc levels, the worse the behavior problems. And then assessing the parent-caregiver-child bond, I think is really important. We ask some of these questions, and we ask these questions because it's really important to make sure that these kids are protected. So kids with ODD are at increased risk of child abuse. Some studies suggest that domestic violence is higher in homes with kids with ODD, though of course we don't know cause and effect on that one. When parents start to lose hope or become depressed or anxious, then the parenting strategies worsen, and then the outcomes are worse for the child. So do those. So I'll go back to that slide just really quick so you can see it again. This is going to be in our charting template though. So let's go through some treatment strategies. We're going to start with parenting strategies because the best evidence right now for treatment strategies is parenting programs. This is called Incredible Years. It's at incredibleyears.com. It's an evidence-based early intervention program, and that includes teachers, parents, and child curricula. It has 40 years of research supporting the program. The problem is it's expensive. It's about $550 for a year. What I've seen it typically used in, usually like a school or a counseling group or someone gets a grant from somewhere to use this Incredible Years program, and then usually they put them on free for the community. So it's not quite like it's a little bit harder, at least for me in Missoula, Montana. It's like hard to be like, just do the Incredible Years program. You have to find someone who is kind of hosting one of these support groups where they're using the curriculum, unless you want to spend $550, but it's not really meant for like direct parents to be used. So, but again, child and family services programs, a lot of them do use this. I think the majority do. And this is called the Triple P Positive Parenting Program. Ooh, how's that? So it's on triple-p-parenting.com. It's an online parenting program. I think I've got another slide so you can see the logo here. It's an online parenting program. It's backed by a tremendous amount of research. There's a baby program, a kids program for under 12, and a teen program. And the cost on that one is $93.45 at this time. And that's for 12 months of support. So I feel like that's reasonable-ish depending on, you know, the resources of your families and your practice. So. And then this is called Parent-Child Interaction Therapy, or PCIT. It's an evidence-based treatment for children with behavioral issues. These are coaching sessions where a therapist observes through either a one-way mirror or a live video feed the parent-caregiver-child interaction. And what happens is the caregiver has like a little ear device, and the therapist starts giving them coaching instructions in real time. There's several treatment phases. It can take a while, so 12 to 20 sessions is what they often do, and it's available for kids up to 8 years of age. You can go to pcit.org, see the website, and click on the Find a Provider. Of course, larger cities might have a lot more resources than smaller cities or towns. I feel like that one might be a little harder to get parents involved in. The kind of the problem with it is, I don't know. I mean, sort of like admitting that you need help, I guess, is the problem for parents. But the books, I think, are a great option for all parents, as long as they can afford a book, which most can. The Defiant Child is kind of an old book. It was published in 1997. Some of the information might be a little bit dated, but the reviews are really strong. It has, you know, extra disciplinary tools that are just different than what works in a normal kid. And it helps parents understand the diagnosis better. The Kasdan method, I don't know if I'm pronouncing that right. That's a really great book, heavily recommended by multiple groups, and it gives useful parenting strategies. to avoid power struggles, which is really important for kids with ODD. It shows you how to use your tone of voice, how to touch, because some kids are hyperreactive to touch. So like how to use calming touch, how to do like little practice sessions with kids, how to adjust the strategies for different age kids, and lots of different advice on that one. And then The Explosive Child, if I'm correct, is a slightly newer book, or at least it's been updated more recently, and it's based on neuroscience. And it describes why traditional parenting methods do not work for these kids, which is really important. And it kind of takes out the reward and punishment cycle, because again, both of those tend to not work well, either rewards or punishments for ODD kids. The rewards, what they say for children with ODD is it can be kind of patronizing when you're rewarding them for just what should be like a normal behavior. So kids don't tend to respond to that. And of course, they really don't respond well to punishment. So TBRI is not directly anything related to ODD, but if you haven't heard of TBRI, it's great. It's an attachment-based trauma-informed program. So it teaches principles to children who faced trauma or abandonment. It includes principles of attachment, helps disarm fear-based behaviors, backed by a ton of neuroscience research. So this could be good for kids who are adopted, or who knows, who have, issues in the family. So let's talk about nutritional strategies quickly. Blood sugar balancing is my favorite diet to start with. There is no scientific evidence supporting its use, because it would just be really hard, I think, to figure out exactly how to study this. This is just based on my experience and general knowledge that hypoglycemia plus defiant behaviors equals disaster. So I use like the Harvard Healthy Eating Plate, and we just encourage protein, fiber, and healthy fats at every meal. I believe we're including the handout, How to Balance Your Child's Blood Sugar, as a long handout for parents, so you guys will have access to that. You can read through that. A Feingold diet has some research for patients with ADHD, so I'd consider it for those kids who have ADHD and ODD at the same time. The research is mixed. The Feingold diet basically excludes artificial colors, preservatives, certain things like that. I really only found like certain kids respond really well to it, but not all. And I think that's why the research is sort of mixed. I do that strategy as a trial for most kids with ADHD, though. We're actually going to talk about evidence-based interventions for ADHD in our August webinar, and I should have noted that in our first slide, so maybe I'll roll back to that at the very end. But the dates of our upcoming webinars for the next 2 months are going to change slightly. So usually we do the first Thursday of the month. In July, it's going to be the 3rd, because the 1st is the 4th of July, and the second week, I'm taking my kiddo to a Cub Scout camp. So it'll be the 3rd week. And then we are going to do the 2nd week of August, just so we don't have 2 right next to each other. So just so you guys know. So then nutritional supplementation, this is pretty interesting. There are some studies that support the use of omega-3 fatty acids in kids with ODD, especially those with ADHD. This also may be changing my practice. This is a great and fascinating study. It basically shows that infants who had 250 milligrams of DHA and 60 milligrams of EPA from birth to 6 months of age, and these are in breastfed babies, they didn't find any difference in neurocognitive outcomes compared to the placebo group. But 6 years later, the rate of oppositional defiant disorder was significantly less. So that is a very interesting study. And I usually do not supplement directly babies from 0 to 6 months with fish oil. Sometimes I always do for kids with eczema, but I usually don't supplement everyone. And so I need to consider if maybe we're going to start giving all babies a little bit of fish oil. And then lots of other studies. I won't put all the studies up here, but basically children with behavioral problems, that first study was great. If they do omega-3s plus counseling, they have the best outcomes compared to just omega-3 or just counseling. Fatty acids reduce aggression, they reduce behavior problems. There's lots of interesting ones. And now this one's a little bit different. So this is not just omega-3 fatty acids. This was a trial group, and it divided kids. The kids were aged 11 to 12, and there's 4 groups here. There was a nutrition-only intervention, and I'll read you what they used. Nutrition plus CBT, cognitive behavioral therapy, cognitive behavioral therapy alone, and then a control group. They did supplementation for 0 to 3 months, and then at 3, 6, and 12 months post-treatment, they checked scores. So the nutrition-only group, who had a list of supplements I'll list in a second, had the best effects at 3 months. The nutrition plus CBT group had the best at 6 months, but then by 12 months, all of the results went away. But now remember, they didn't continue supplementing them. They only supplemented them for 3 months. So we don't really, I'm assuming that if you continue to supplement them, they're going to continue to probably even get better. So the supplement included a drink. It was called Smart Fish Recharge, and I'll say the brand name because it's not commercially available. It's only in research right now. It's a product out of Norway, I believe, and it contained 1,000 milligrams of omega-3 fatty acids, and that included 300 milligrams of DHA, 200 milligrams of EPA, 400 milligrams of alpha-linolenic acid, and 100 milligrams of DPA. It had a multivitamin, but I couldn't find what was in it. It had 12 vitamins and 7 minerals, and then an extra calcium, 600 milligrams of calcium, and 400 micrograms of vitamin D. So that's pretty high calcium. So again, they used that as the nutritional intervention. Very cool and great study. And then this study, so this study was so interesting. So this study was, or was this the same study? Sorry, this is the similar one I was showing a little bit further on. So this is the externalizing behavior. So this study is actually using the same Smart Fish Recharge, and then we're checking externalizing behavior. I've got another one really exciting in just a minute though. This study was pretty similar as well. This was a different company though. They did just a micronutrient mix, and that was essentially a multivitamin. It had, you can read the list of different micronutrients. What I find really interesting is that they did not include folate or B12, which I find fascinating because, again, I think some of these kids are over methylators, and there's a significant improvement in aggressive and violent behaviors. This was the one that I was really excited about. So for this study, they supplemented kids with omega-3 fatty acids, and what they ended up finding out was there was less domestic violence in the parents when the kids were supplemented with omega-3s. So in other words, I'm assuming the behavior in the children improved so much that there was less domestic violent events in the adults, which is really interesting. So I hope you guys find that interesting, because I did. Okay, so other considerations, there aren't really a lot of other direct supplements. Obviously, you've already seen that B12, D, zinc, magnesium have been shown to be associated in serum levels, or RBC, zinc, and magnesium. So basically, there's subsets of kids where there's a deficiency that's associated with those, but there's not a lot of studies of like, what do we do if we actually supplement them back? There was one on zinc and they found no effect, but unfortunately, the authors noted that they were making changes in the school dietary program at the same time that they were doing the intervention on zinc. So the placebo group ended up having much better nutrition than they had had previously anyways. So it's hard to tell. There are a lot of studies in zinc and a lot of studies of zinc in all sorts of mental health disorders, including in children. So I would really strongly consider it, even if we don't have maybe the best evidence right now. So I want to talk through, I'll try to go pretty quickly. I know I'm at, I don't know, coming up on the hour. So for those of you who have their cameras on, you give me like a pause if you want me to go a little bit slower in any of this, but this is straight out of my treatment plan. So you will have the copy of that. So I'll go through this pretty quickly, and then you can ask questions in Q&A, or you can just wave your hand if you want me to slow down a little bit. But this is the direct strategies that I use for children with MAOA. So this is the language that I'm talking about with the parents. This is exactly what I'm telling them. Is like, this is the neurotransmitters. This is what's happening. Your child's having difficulty breaking them down. I always remind them that just because you have something in a gene does not mean that you're doomed to anything. Really key for MAOA patients is high intensity exercise. I don't know of any other way of getting around this other than just burning it off. It is number one intervention for MAOA. And then weirdly enough, some of these kids and adults, and this is actually known, there's higher rates of MAOA in the military, for example. In extreme stress, some kids and adults actually do very well. So like snipers, incredibly stressful situations, their head will clear, and they can perform actually to a very high degree. So it's a little bit paradoxical for in some situations. So always recommend an athletic outlet, individualized sports, not cooperative sports for most of these kids. Taekwondo, martial arts, jujitsu, biking, skiing, track, something like that. Sleep is really, really critical. Some actually get worse with melatonin because there is a backwards effect. So if we have melatonin, then our tryptophan, we end up having more tryptophan. It doesn't go down the melatonin pathway. It ends up going to serotonin. So those kids can get vivid dreams. If they have vivid dreams, you need to back down the dose of melatonin or stop. Mild herbs can help, but passion flower, it does act on GABA receptors, but can actually inhibit MAOA in high doses. So I've actually never clinically seen that happen, but just be aware of that. Stomach aches are super common. We already talked about dietary adjustments for that, but that usually we'll do like a gluten-free, dairy-free diet challenge just to see, because a lot of the kids do have like IBS-like symptoms. And then this is really important to understand what medications these kids do well and do not do well on. Almost all these kids, like I'd love to have kids not be on meds, but most of these kids have tried meds before they make it to my office. Most do worse on SSRIs because there's too much serotonin, not too little. Every once in a while, a patient will do okay, like Lexapro or fluvoxamine, they seem to do better. Most do worse on stimulants, but again, some might do okay. And then these are the patients that always have paradoxical reactions. If you have a patient that comes in and says, I react backwards to everything, I would always think about this, the MAOA gene. Of course, you should never do an MAOI. They already have problems with MAOA. Quetiapine is actually a serotonin and other things. It's a serotonin antagonist, if I'm correct. Yeah, antagonist. So that actually can be helpful. But it is strong as heck. It's very difficult to get off of. And the kids end up being very sedated, and there is a lot of weight gain. And then again, watch for overmethylation with methylfolate, methyl B12. They're the ones that feel terrible. And sometimes they can have paradoxical fatigue too. It's like a burnout fatigue. They're overstimulated to the point of fatigue and depression. Supplements that we can give to improve the function, riboflavin, MAOA is a FAD-dependent enzyme. You can see my doses there. Magnesium, super helpful. And again, you guys can read through this a little bit later. Omega-3s, obviously. Iron is a cofactor in that pathway too. I like iron bisglycinate. And then I would just, either low dose supplemental iron for kids that are not iron deficient, just to prevent deficiency, or a little bit higher dose if kids have iron deficiency. And then zinc, I probably would do zinc. I love the zinc lozenges during cold and flu season anyways. So this is pathological demand avoidance. This is from my PDA handout. So again, we've already talked about this, but describing to the parents the extreme level of anxiety that these children are experiencing. Once parents understand that, then they see it. They start to realize that their kid is not just being defiant, that they're actually just melting down. It is life-changing for these kids and for these families. This is, again, straight out of my handout. This is their feeling of loss of control. The parenting strategies are very creative. It's like creative non-compliance, only this time we're trying to do creative compliance. So using indirect language is really helpful. I wonder whether, or timing kids. Hey, let's see how fast we can get your shoes on today. providing choices, or just letting the kids kind of manage it on their own. I know that sounds pretty paradoxical, but it actually works much better. These kids are usually highly intelligent, by the way. So if you can rationalize with them ahead of time and not just throw demands on them, it can be helpful. Build trust, use humor. Humor actually is very, very effective for these children. Collaboration, planning ahead, all of these are good strategies. So this is from the Pathological Demand Avoidance Society, which is based out of the UK. And I'm sorry I didn't give you guys the URL, but I think it's in our full document there. And they have a little panda, which is a little confusing because then we also have kids with pandas. And that's not what this is, but they're talking about just strategies. They have lots and lots and lots of resources for parents, for teachers, for caregivers, for all sorts of different areas in life, so that the other people around the child have resources for helping them. And then really quickly, let's go over pharmaceutical interventions. This is specifically for ODD, not for pathological demand avoidance. We're switching gears a little bit. So stimulants, even though I'm not a big fan, the research is very clear that treating ADHD does improve symptoms of ODD. So, if we increase dopamine in the brain, then we improve attention and focus and self-control. So do be aware that the use of stimulants, though, there's a lot of side effects with. So let's actually see this one. This is the study that made it so clear that co-treating kids or treating kids for ADHD really improves their ODD. But those adverse events, I don't know if you guys can see it. I'll read it to you. The adverse events were decreased appetite in 25% of the kids, insomnia in 19%, headaches in 18%, abdominal pain in 10%. And then they had a significant but not it didn't meet the confidence interval. They did have a decrease in body weight. So sometimes these are kids that already struggle to eat. So it can be, maybe not great to not have them eat more. It can be even worse. But that said, again, I would use stimulants as last line, but some kids might need it just to function. This is on clonidine. So clonidine is an alpha-2 adrenergic agonist, and it's used off-label to treat oppositional defiant disorder, especially when it's combined with ADHD. I do have a couple of kids in my practice who are on that medication, and in general, I like it a little bit better, although it's very sedating. So it does reduce symptoms of hyperactivity, impulsivity, usually improves sleep as well. And then this one was so cool. So is intranasal oxytocin. So we talked about oxytocin and vasopressin already. Oxytocin is being studied right now quite a bit in autism spectrum disorder. There was actually just an article maybe a month ago in using oxytocin in ASD level 1 patients, and I think it was in adults, and it showed significant improvements in bonding and a greater ability to recognize social cues. But then it's sort of like raising this question in the autism community of what they want, but I don't really want to. I don't know if I want to engage in society any more than I am. So it's a really interesting kind of conversation going on. It does work. So just because of learning about this relationship between vasopressin, testosterone, and oxytocin, I started looking up to see if there was trials, and I found this trial in clinicaltrials.gov, but I could not find the actual study. So I actually emailed the author, and he gave me the preprint, which actually was released April 2024, but it just hasn't, I don't know, hit PubMed or something yet. So they studied intranasal oxytocin with aggression and disrupted mood. And then they also completed functional MRIs, and it showed changes in the prefrontal cortex after oxytocin supplementation and improvement in clinical severity. So that's pretty exciting. I think that's really neat. So I'll go back to this slide for just a second so you can see the dosing. They're doing 24 IUs a day of intranasal oxytocin or less, or 12 IUs if the kiddo is less than 40 kilograms. And then the last thoughts, other considerations, naturopathic considerations, neurofeedback can be really helpful for kids with ADHD. probably helpful for kids with ODD too. I haven't tried for ODD alone, but again, I've yet to have an ODD alone patient. Other herbal medicines or supplements, there is no research on this. But all of these have research for other things. So if there's L-theanine, if they're presenting symptoms of anxiety, St. John's wort, if the presenting symptom is a depression, resveratrol actually has been shown to decrease the need for stimulant medications in kids with ADHD. NAC, if the symptoms of OCD are present, I think hopefully most of you guys know that NAC has been shown to be helpful for OCD. And then saffron, if there's a presentation of depression and anxiety. Personally, I find in practice that saffron's very effective for the mixed depression and anxiety, especially when there's like a brain fog kind of a presentation. So I'm doing pretty good on time. Okay, feel free. I've got one question here that I'll answer, and then feel free to pop some more into the chat if you have, or certainly feel free to unmute yourself. I know I went through a lot. So let me answer this one first. Okay, so it says, with the zinc deficiency you mentioned seeing in neurodivergent kids, do you screen for this with labs, and do you have ranges you use, or do you just treat presumptively? Yes, is my answer for both. If parents can afford it, when I get that first set of labs, remember some kids with autism are going to have a really hard time getting a blood draw on. I do really want us to get one at some point, because I want to get vitamin D levels. I do like to get the zinc level. If they are, so if we get the RBC zinc, and I think that's run out of Mayo Clinic, I think even here, like at CMC labs, they still send it out. So if it's below the reference range for RBC zinc, then for sure, we diagnose with zinc deficiency. But even if it's in the reference range, or say maybe low normal reference range, sometimes I'll still supplement with zinc. Remember that they're not going to get copper deficiency until, we're supplementing. For adults, it's usually 50 to 100 milligrams with no copper. So for kids, giving them 10 milligrams of zinc ongoing is extremely unlikely to cause a copper deficiency. And there is quite a bit of research that a zinc copper ratio is associated with worse mental health outcomes. So like worse clinical autism symptoms, or anxiety, or OCD symptoms, or things like that. So we kind of want higher zinc than copper anyways. Oftentimes I'll tell families to just take a break from zinc supplementation over the summer anyways, just to reduce the risk of a copper deficiency, but it usually doesn't happen. So zinc actually is relatively common for a functional nutrient deficiency in children. The zinc containing foods are not always the tastiest foods. So kids who are picky at all are very likely to have a zinc deficiency. Anyone else have anything else? Are we good? All right. If you guys have any other questions or want to go over a case or anything else, let me know. You're welcome to send me an email as well, and we can always discuss these more. But thanks for being with me. I love this topic. I hope you guys are able to help your patients with ODD. Boy, I'm just super, super, super passionate about this subject because it makes such a difference in the lives of kids and in the lives of parents. So you guys take care. I'll see you next month. Again, will be the third Thursday of the month, and we'll talk about botanical medicine for anxiety.